Welcome to Coronavirus Brief Update number 8 for Granville County EMS, dated October 8th, 2020. Our last update was towards the beginning of the summer as we were starting to see the surge following Memorial Day. And I think it's time that we have another brief update because we're about to see some pretty major changes in what's coming over the next few months. Also, I wanted to take advantage of this update to keep you in the loop as to some pretty significant protocol changes that are occurring that have nothing to do with coronavirus. We had our annual EMS medical directors meeting for the state of North Carolina yesterday with the Office of EMS, and there are some pretty significant changes in terms of behavioral health, ketamine, intravenous access that are coming, and so we'll discuss those as well. But first, we'll start with coronavirus stats. As always, we start with the North Carolina stats, about 220,000 confirmed cases, 3,500 deaths, and almost 1,000 patients hospitalized. Unfortunately, this number is uptrending and has been over the last few weeks. As we've discussed before, hospitalizations is really the only accurate number as to what's going on in the state. And unfortunately, we're starting to see that uptick again, and we're going to talk about why that is. Looking specifically at Granville County, about 1,800 cases. And interestingly, most of that growth has been outside of the Butner prison system. You'll remember in previous updates, since this epidemic began, the Butner prison system has pretty consistently accounted for half of the cases at any point in time in Granville County. That held true up through about mid-July, but since July, we've actually seen a real tapering of the cases within the Butner prison system. I don't know if this is due to policy changes or if the virus has sort of worked its way through that population, so to speak. It's hard to say what accounts for that, but since then, most of the growth in the county has been outside the prison system, but still within institutions. So when you look at deaths, for example, there's only been about 5 community deaths. Of the 50 deaths we've had, 45 of those have been institutionalized patients, about half in Butner, half in long-term care facilities. And that's where we're really seeing the growth, are these long-term care facilities, assisted living, things like Universal, Murdoch, etc. Now, I mentioned we're starting to see an acceleration again, and that's really the reason for doing this update now, is we are on the precipice of what's probably a very significant acceleration in cases, and there's a few reasons for this. First, Labor Day. If you recall, Memorial Day back in the beginning of the summer acted as a super spreader event because of travel and people being more lackadaisical. We know that a lot of that summer surge had to do with changes in behavior around Memorial Day. Labor Day is projected to be even worse. Looking at travel data, we know that people traveled much more for Labor Day than they did for Memorial Day. You look at travel statistics for Hawaii, Las Vegas, Florida, places people commonly go, much more active than they were for Memorial Day. And so in theory, there should be more spread. Also, another reason for acceleration is schools are back in session. Not every school, but many are either full-time or some type of hybrid model. Obviously, that mixing helps spread respiratory viruses. A third reason is we're really starting to see some mask fatigue. And I've noticed this with myself. I've noticed it with EMS providers, with ER providers. We're just tired. We're getting bored of the amount of vigilance that's required to always wash our hands diligently, don't touch our face, make sure that we always have masks and gloves on. And there's this tendency, after 6 months to start getting a little bit more lazy about that. But unfortunately, that is going to accelerate viral spread. And then another reason we're seeing acceleration is how people are treating risk. So there's this idea, the normalization of risk. And what I mean by that is you start doing something in one area of your life, and because of the amount of risk that you're taking, you mentally assume that anything else that feels less risky than that is okay too. So let me give you an example. Maybe you have kids and your kids are back in school. So, throughout the summer, maybe you weren't doing a lot of play dates, but now your kids are in school with each other. And so you feel, well, if they're in school all day with each other, then it really doesn't matter if they play with each other outside of school. So you're letting your kids do more play dates. And then you're like, well, the kids are having play dates, and they're just coming home and exposing the parents. And so it's probably okay for me to hang out with my kids' friends' parents because that's really no different. And so we start adding on all these activities that we've decided are okay because of what we're doing around school. The reality is we should be doing the exact opposite. If our kids are back in school, we should be less social than we've ever been. We should not be going to restaurants because what we should be doing is changing our behavior to offset the additional risk that comes with having our kids in school. By opening schools, most states should have moved backwards in their opening, right? They should have reclosed restaurants, reclosed bars to offset the risk of opening schools, and then you can wait 3 to 4 weeks and see what happens and then maybe resume getting back to normal in other areas of life. But that's not how the human mind works, and that's not how we behave. We assume that if we're doing risk A, then anything that's less risky than that, we can also do. And so, for all of these reasons, we're expecting a pretty significant acceleration going into the fall. You can see on this graph going through September, you can see the peak that we experienced after Memorial Day. And remember, changes in behavior don't really start to change the numbers for a couple weeks. All these things that happen early November, we should just be starting to see the effects of those now. And we are. We're starting to see an up creep in virtually every state in the country, no matter what metric you look at. And most models predict that we're probably going to get to a volume of about 4 times what we're seeing right now. So clearly, you look all the way back in March, April, when we were so worried about coronavirus, for good reason. But the numbers then were nothing compared to what we're going to experience over the fall. And so I just want to reinforce that. And please, please, please don't get complacent with PPE because the risk now is greater than it has ever been. Do remember that transmission is usually occurring from asymptomatic people. People become contagious probably about 48 hours before they show symptoms. And also a fair number of people don't ever really show symptoms and yet are still contagious. And so a lot of people are transmitting the virus either before they get sick or because they're never really going to show signs of illness. So your partner in the ambulance, your coworkers, your family members, your kids going to school, everyone is a risk factor, and you should react accordingly. Also, please do not come to work sick, even if your symptoms are very minor, even if you're convinced that this is not COVID and you just think it's allergies or the flu or whatever. Please do not come to work sick. Contact myself, Jonathan, infectious disease at the hospital. Let us make these decisions together. And I also just want to mention, particularly as we go into the fall, particularly as we get close to the election, try not to get into political debates with patients. This is something that's been happening in the ER, and not just at Granville, but all around the Triangle, is there's been a lot of friction between healthcare providers and patients regarding, masks, behavior, and try not to get into those sort of political, passive-aggressive conversations with patients. It's hard to do, but, don't get sucked into, COVID isn't real or I shouldn't have to wear a mask. And, you can tell your patients facts, but try not to make those facts, politically oriented. And it's very hard to do with the politicization of COVID. But we're medical providers, we're factual, we can tell our patients, what's in their best interest medically. But, again, try not to get into political debates with patients. So that's all I really want to say about COVID, is to just kind of make sure we're all on the same page as we head into October and we start to see those numbers shift greatly. What I'd like to do is take a break from COVID for a second and just give you some heads up as to what's coming down the pike. And a lot of this is in response to the North Carolina Office of EMS, as well as the North Carolina Medical Directors Conference that occurred this week. And I just want to give you some updates as to where things are headed. So there's actually quite a few protocol updates and some news. So probably the biggest news is ketamine is finally approved. All of the hoops that we had to jump through in terms of Office of EMS, State Medical Board, everyone has finally signed off on this. So ketamine is now just within the scope of practice for all EMS systems in North Carolina. You don't need any special waivers or permission to carry ketamine. But, and there's a but coming, but right as the state of North Carolina approved this, there's been some changes on the national level. So the large national group of anesthesiologists just recently came out with a position paper that says that EMS should not be carrying or using ketamine. And it's really interesting. The reason that they did this is because there have been a lot of reports, particularly in other states, of law enforcement strongly encouraging EMS to use ketamine a lot. And this is in direct response to things that have happened recently around negative publicity for law enforcement as relating to Black Lives Matter, the overall increased scrutiny of law enforcement, the increased use of body cameras. Basically, law enforcement, at least in some jurisdictions, would rather sedate people than have to get involved in a physical altercation, because then they avoid the risk of the situation escalating, of, aggressive force having to be used. And so what has been happening, at least in some places, is law enforcement has been trying to strongly encourage EMS to use ketamine in situations where the patient is just mouthing off at the police officer or resisting arrest or being, verbally or physically aggressive. And these are not usually situations in which ketamine is indicated. Ketamine is reserved for those patients who are at extremely high risk of harm to self or others, who are agitated and violent and cannot be controlled any other way. And the decision rests solely with the EMS provider. It's based on the risk benefit of using ketamine, as well as what's in the patient's best interest. And the decision should have nothing to do with what's in law enforcement's best interest or what their preference is for handling the situation. So now we have this issue at the national level, the largest group of anesthesiologists, which are usually responsible for determining how sedation should be used at a national policy level, are basically saying that EMS in the United States should not carry ketamine. The American College of Emergency Physicians, as well as the National Association of EMS Physicians, both have position papers saying that they should be able to carry it. So because of this, the state has asked North Carolina EMS agencies to hold off on pushing ketamine into the field, even though technically it's now approved. And so I just wanted to give you that update because some of you may be wondering, well, why aren't we doing Con Ed on ketamine so that we can start getting it on the trucks? Well, that's why, because we're sort of in this holding pattern until this issue is better hashed out. So that's what's going on with ketamine. Another protocol change, a little bit smaller, is that they are going to change the verbiage around intravascular access. So one of the things the state has noticed through QA is that people are still hesitant to do IOs, particularly in patients who have a pulse. And there's a lot of confusion around the 90-second rule, the 3 sticks rule. So basically, as far as the Office of EMS is concerned, is they want you to use IOs aggressively. If a patient is critically ill, if they're crashing, if they want you to jump to it. But even in patients who are relatively stable, if you can't get IV access and it's warranted, they want you to do IO. And they're changing the verbiage so that it's not that you have to wait 90 seconds. It's not that you have to wait for 3 IV sticks. They just want you to know that that's the maximum. They would much rather you use IO earlier, more aggressively. In other words, it's being underused, and the Office of EMS is changing some of the protocol language to try to make it easier for providers to feel comfortable using IOs more frequently. There's also some additional guidance coming on accessing indwelling devices, certain ports, things that we don't do a whole lot of in our system, but you'll see that reflected in the protocol as well. So probably the biggest changes that are coming are with the behavioral health protocol. So they're actually taking the current behavioral health protocol and dividing it into 3 separate behavioral health protocols. They're also adding a procedure protocol on verbal de-escalation. So verbal de-escalation is now a procedure, just like needle thoracotomy is a procedure. The point of all of these changes, in a nutshell, is to improve decision making around behavioral health emergencies. And the Office of EMS, their overall goal is to strongly encourage the use of verbal de-escalation, as well as encourage the use of benzos for agitated patients or patients with lots of anxiety. They want you to have a lower threshold for using those and to use them earlier in patients who are willing to take those things. In other words, to de-escalate what's going on in any way possible, and really reserve ketamine for those situations in which the patient is aggressive, violent, can't be reasoned with, may have other drugs on board, a very significant psychiatric decompensation. And I don't have those protocols to show you yet. They're not officially in the protocol booklet, but when they do come out and are finalized, we will obviously have a lot of continuing ed around these. And then the last thing I'll mention is that they are significantly revamping all of the procedure protocols. And what they're doing is they're inserting a lot of pictures. So when you look up needle decompression, for example, there's going to be multiple diagrams demonstrating exactly how to perform that technique. So instead of just the written description of what you should do, they're trying to make the protocol much more visual, with the hopes of improving your understanding of the technique, especially for these procedures that you may not do that often and may have to refer to your protocols when they come up. So those are the big protocol updates. I just want to come back to ketamine for a second. So when ketamine finally does work its way into our system, it's really going to impact 2 protocols. First, ketamine is going to be an additional option for pain control. So in addition to morphine and fentanyl, you'll be able to use ketamine. Now, the research on ketamine as a standalone agent, for example, as the first drug that you push for pain control, is not that great. Ketamine's real value seems to be as an add-on pain control. So let's say you give a dose or 2 of morphine, fentanyl, those things are not achieving adequate pain control. At that point, adding a low dose of ketamine on top of what you've already given can have a real synergistic effect and can be very effective for enhancing pain control. And the good thing about low dose ketamine is it does not alter the patient's mental status the same way that high dose ketamine does. The second protocol that will be impacted is the one we've already discussed, the behavioral health protocol. And as we said, that's actually going to become 3 protocols, one of which is going to specifically deal with the pharmacology. And again, the emphasis will be on verbal de-escalation, situational de-escalation, benzos for patients that are willing to take them, that you can get them on board, and really reserving ketamine for those extreme situations in which there really appears to be no other alternative. One other thing that they're going to change in the behavioral health protocol is about scene safety. So, and this is a point that is very important to make, and I just want to make sure we're all clear on this. So if you arrive on scene and you make patient contact and the scene becomes unsafe, it is not patient abandonment to leave. There have been some recent incidents where EMS crews have arrived on scene. Things have changed on scene dramatically. The situation was clearly unsafe, and they were unwilling to leave for their own safety because they were worried about patient abandonment. Scene safety trumps everything else. Now, if you have to leave a scene, if there is any way to do it, try to do things that will keep people safe. Try to take the patient with you if that's a possibility, things of that nature. But you have to keep yourselves safe. And the Office of EMS is now trying to be very clear about the fact that if you are in an unsafe situation and you have no choice but to leave, that is not considered patient abandonment. So we'll talk a little bit more about that along with everything else we've talked about in terms of behavioral health when these protocols come out. Obviously, there's going to have to be CME on the behavioral health protocols, the three new ones, as well as ketamine as a drug and how to use it safely. And to be honest, I think these will probably take a backseat to COVID as COVID dramatically escalates this fall and winter. I have a feeling that these things are coming down the pike more in the spring or summer. But again, I want to keep you in the loop as much as possible. So if you have any questions about any of that, you can always feel free to reach out and contact me or Jonathan or Alan. And again, as always, thank you for all that you do. Stay safe, and we will continue to do these brief updates as the situation evolves. Thank you.